Pediatric OCD is one of the most painful childhood mental health conditions. It is not about being a neat freak or wanting pencils lined up. The condition is driven by two hostile forces. First come the obsessions, intrusive, terrifying thoughts that flood a child's mind. To escape that intense distress, the brain demands compulsions, repetitive physical or mental actions designed to turn the fear off. This flowchart reveals the OCD loop. An intrusive thought spikes distress, triggering a desperate compulsion. These rituals are often invisible to adults, involving rapid internal counting, silent mental review, or constant reassurance-seeking, asking parents repeatedly, "Am I a bad person?" Because these routines are often internal, children suffer silently in plain sight for years before anyone realizes they are trapped inside this cycle. When parents or teachers see a child in distress, the human instinct is to comfort them. We want to sit down, talk through the fear, and assure them everything is fine. But applying generic reassurance-based talk therapy to pediatric OCD actively worsens the disease. This diagram shows exactly why. By assuring a child their fear isn't real, the adult unwittingly performs the compulsion for them. External reassurance temporarily drops the anxiety, but strengthens the core OCD node, guaranteeing the fear returns stronger next time. Standard talk therapy fails to cure the anxiety. Instead, it feeds the exact mechanism keeping the child trapped inside their own mind. Treating this condition requires a highly specific, evidence-based intervention called exposure and response prevention, or ERP. This side-by-side comparison shows the mechanics. Left, the broken reassurance loop. Right, the ERP process. A clinician exposes the child to their trigger and structurally blocks the compulsive response. By sitting with discomfort, the false alarm distress signal slowly shrinks, severing the neural connection. Depending on clinical severity, a licensed professional might also prescribe SSRI medications to help stabilize the brain's chemistry while this behavioral work takes place. ERP functions as active neurological rewiring, separate from the verbal processing of traditional counseling. The clinical science is clear, but families immediately hit a structural bottleneck. Most generalist community therapists simply do not have the specialized training required to deliver ERP. Desperate families bounce between well-meaning providers. They waste critical developmental years in reassurance-based therapies, while the child's compulsions grow more severe and entrenched. Possessing an effective clinical protocol has limited value if children cannot physically get into a room with the specific clinicians trained to use it. Solving this access gap requires bypassing the community clinic entirely and bringing the specialized clinical bench directly into the school system. This is the exact structural model driving MentalSpace School. They provide a dedicated bench of therapists specifically trained in ERP and trauma-focused cognitive behavioral therapy to K-12 students across Georgia. This split screen illustrates how they bypass community waitlists. A student in a standard school building connects via a secure data bridge to a vast network of medical professionals, receiving same-day teletherapy without ever leaving campus. The platform operates under strict regulatory frameworks, ensuring complete HIPAA and FERPA compliance, while also supporting districts in meeting the upcoming HB 268 compliance deadline for 2026. Integrating this specialized teletherapy network directly into the education system physically removes the geographic and systemic barriers keeping students from care. It also removes financial barriers. MentalSpace accepts Medicaid at zero cost to the family, alongside major commercial insurance providers like Blue Cross Blue Shield, Cigna, Aetna, and United Healthcare. Deploying this precise clinical model produces these results: an 89% improvement in attendance, a 92% reduction in anxiety, and an 85% family satisfaction rate. Behind these percentages are children who have finally stopped the exhausting rituals and reclaimed their focus. Educators and parents looking to bring this specialized clinical tool to their district can visit mentalspaceschool.com or reach out directly at mentalspaceschool@chctherapy.com. Pediatric OCD is a painful condition that often goes misunderstood, but when schools provide immediate access to the specific clinical tools designed for it, a disorder that once felt insurmountable becomes a problem with a clear, proven solution.